Shamila, have everybody come? Okay. Good evening, everybody. Welcome to our fifth webinar organized by the Faculty of Critical Care of College of Anesthesiologists and Intensivists of Sri Lanka. I am Dr. Bimal Kudaganage, Head Faculty of Critical Care Medicine, College of Anesthesiologists and Intensivists of Sri Lanka, and I'm consultant anesthetist at National Hospital of Sri Lanka. The College of Anesthesiologists and Intensivists of Sri Lanka have organized various educational activities to improve our knowledge, skills of clinicians who manage COVID-19 patients in the country. We have conducted many courses for doctors and nurses in the Ministry of Health with collaboration of the Ministry of Health in Sri Lanka. This series of webinars organized by the Faculty of Critical Care Medicine is a part of the effort to improve the knowledge of clinicians who manage COVID-19 patients in the country. COVID-19 is a disease involving mainly the respiratory system. Patients who are admitted to our HDUs and ICUs usually require high concentration of oxygen and perhaps ventilation during management of pneumonia. Therefore, imaging of lungs is a critical investigation for optimal management of these patients. Therefore, we take this opportunity to share the experience of clinicians from other countries who have had massive waves of COVID-19 pandemics, which will help our colleagues to learn. The topic of the webinar is radio diagnostics for COVID-19. It is my pleasure to introduce two eminent speakers as resource persons for this webinar. Professor Ashu Balla is a consultant radiologist from All India Institute of Medical Sciences, New Delhi, India. And our second speaker is Yale Tang Cheng, a physician and associate professor who is a specialist in point-of-care ultrasound from Madrid, Spain. Hello, Professor Balla. Hello, Yale. Good to see you. I would like to thank you very much for accepting our invitation and welcome. I welcome both of you for our webinar. Just housekeeping messages. We would like to invite you all to forward your questions in Q&A chat box, basically chat box, and time permits, we will try to answer your questions at the end of the session, at the end of the both lectures. So let me introduce our first speaker, Professor Ashu Balla. She is a professor in radio diagnosis at All India Institute of Medical Sciences, New Delhi. She's been serving there since 2001. She is also the president of Society of Chest Imaging and Interventions. Her areas of interest: thoracic radiology, head and neck radiology, with special interest in interventional radiology. She has over 260 publications in national and international journals and delivered over 300 invited talks. She has 8 books on the subject, contributing to over 80 chapters in various publications. Today, she will deliver her talk on topic of chest radiograph, chest X-ray and CT findings in COVID-19 patients and its clinical use. Over to you, Professor Balla. I think you need to unmute your mic.
Thank you, Dr. Bimal. It's a pleasure to interact with you all. Is my volume good now?
Yes.
Yes, so I work very closely with the critical care community at our hospital.
Hello.
And we have a weekly MDT together. And so give me a moment. I'm going to share my screen and start. So Dr. Bimal, is my screen there?
Yes, we can see.
So should I begin?
Yes.
Okay. So
Yes,
today,
there's a bit of a breaking of your voice, Professor Bala.
just a moment. Tell me now. Is it good?
So start, please. You can start. Yes.
Yeah. You can hear me well, Dr. Bimal? Can you hear me
Yes.
well? Yeah.
Yes, we can hear you.
Okay, so my first talk is now on chest radiographs and CT scans, and Dr. Chen is then going to speak on POCUS after this in context of COVID-19. COVID-19, of course, is a multi-system disease, but as Dr. Bimal said, that it's the lung which takes the hardest hit. So we will be discussing COVID-19 pneumonia, and I will be focusing on chest radiographs and CT scan. For purpose of discussion, actually, there are three situations where we need to image patients, and that's how the little aim of imaging differs. One is patients who are not yet COVID proven. That means they walk into ER and are COVID suspects. Second are patients who are RT-PCR proven. And then I'm going to address some specific clinical situations also. Now, when we come first to the role of chest radiographs, actually chest radiographs for us have been the backbone of imaging.
I don't know. Where are you reading?
In two settings. Yeah, I think we'll have to
No, I
put all
said
mics
several
off.
feet per day. Yeah.
Post. Yeah, could you just request all participants to put mics off? Yeah, thank you.
Can you all mute your mics, please?
Yeah, so chest radiographs, basically we are using, form the backbone of imaging in COVID-19. And why is that? Because of the availability of portable radiographs in the ER, in wards and ICUs. Also from the beginning of pandemic, sanitization of the equipment, that is that the radiology suite should not turn into super spreader sites, has been a concern. And in this context, portable units are a lot easier to sanitize and kept clean. And because they are less expensive, you can mark special units for the COVID-19 imaging. And hence this, cross-infection is also less. So it's point of care, it's low cost, and it's easy to sanitize. And of course, the concern regarding radiation also is less. So you can use it far more frequently than you can use a CT scan. We first come to the setting of COVID-19 suspect. So when to do a chest radiograph? Basically, whenever the patient fulfills the WHO definition of SARI, that means that patient has fever without any non-respiratory cause, accompanied by a tachypnea or hypoxia, or in patients who are high-risk patients, and even without the respiratory compromise, but have fever, and during an ongoing pandemic, when we have suspicion for COVID-19, we can go in for chest radiographs. If you see a chest radiograph like this, actually, you can be highly confident that you are dealing with COVID-19 pneumonia. Not to say, should I say, positive predictive value or specificity of any test is dependent on the prevalence of the disease at that time point. For instance, in the pre-COVID-19 times, when we did not have any COVID-19 pneumonia, if we saw a chest radiograph like this, we would have called it a reverse bat wing appearance, which means highly suggestive of an eosinophilic pneumonia. But in the current context, this is the most characteristic and probable pattern which has come to be associated with the SARS-CoV-2, a peripheral consolidation, which is subpleural with somewhat mid and lower zone dominance. So if you get this pattern in the ER itself, it helps in quick triage of patient. We can move patient into the COVID-19 wing, even while we are awaiting CB-NAT or RT-PCR. Now we, have divided chest radiographs into the types of patterns that you can see. So actually, apart from classical pattern, we have observed several other patterns which are suggestive of COVID-19 pneumonia. It's dominated by ground glass opacities and consolidations, but these may either be peripheral subpleural in distribution. These can be lower zone in distribution, can also be along the bronchi, which is called peribronchial, can be multifocal randomly, can even take on this ball type pattern or have an overt ARDS pattern. So we have divided this into 6 patterns. And lastly, are rare patterns, which like cavitation, collapse, which usually you will not see in COVID. If you want to catch these patterns and roll of chest radiographs, you can see in this open access review of ours, which will discuss these patterns. Now, what if you see a radiograph like this in a patient of SARI? So even during the current ongoing wave, if we see a pattern like this, which is lobar consolidation with breakdown, because we would label it as a non-COVID-19 pattern. So unilobar consolidation with cavitation with or without pleural effusion gets labeled as non-COVID-19 pattern. So in a final conclusion, you should be able to tell after seeing the chest X-ray whether it's normal, it's classical for COVID, or it's not a COVID, or somewhere in between. People have attempted severity assessment on chest radiograph also, but it has not picked up and been adopted so universally outside of research protocols, and severity assessment for known patients has mostly been done in CT scans. Now we come to COVID-19 positive patients. I already said that portal radiographic unit, depending on how your patient is doing clinically, you can do it every day if they are in ICU, alternate day, twice a week, once a week, depending on the respiratory status of the patient and the underlying risk factors wherein you may need to do chest radiographs more frequently. It's an immensely useful tool, needless to say, in ICUs, because you cannot do so many CT scans. You can't move patients on HFNC or an IV up and down. So the moment you get, new appearing opacities, like in this patient of ours on follow-up, the left lower lobe consolidation comes, we know that patient has developed HAP, is obviously accompanied by other clinical signs of deterioration and onset of fever or rising counts. Complications such as pneumothorax are easily detected. You see, in subacute phase of COVID-19, patients are developing pneumatoceles, like I'm now pointing to a pneumatoceal. And if you see the inferior wall of this pneumatoceal, actually there was a big point of rupture and there's a tension pneumothorax almost. The dome is not diaphragm, is not flattened, but there is a substantial mediastinal push. You can see pneumatoceles on the other side also. And there is a BPF. So that is why, despite the presence of the tube, the lung has not expanded. So all these kind of complications are picked up easily on chest radiographs. Not to say that patients cannot develop pneumomediastinum without pneumatoceles. A lot of patients of COVID-19 pneumonia are developing spontaneous pneumothorax, even in the absence of ventilatory support or development of pneumatoceles. Spontaneous pneumomediastinum and pneumothorax is reported. But in this patient has gone on to develop pneumatoceles, which are related to COVID-19 itself. You can get pneumatoceles due to superadded staph also. Now we come to CT scans, again in the same order, that what is their role in diagnosis, what is their role in management, and eventually in follow-up. What kind of CT scan should you order? So by default, the standard CT scan which is being done today is an NCCT or an HRCT. What happens in today's scanners are that you can write either of these. Actually, the HRCT, as described earlier, that you have to do a high resolution 1 mm scan, is now a question of reconstruction, which means we acquire a non-contrast scan and we make the high resolution scans out of this. So you just need to decide whether your patient should get contrast or should not get contrast. If you are giving contrast, it should mainly be used to assess vascular complications. So whenever you suspect pulmonary embolism, when the D-dimer goes in, or even in situation where chest radiograph looks normal, but the SpO2 is low, so we are suspecting microthrombi, we should go in for a CTPA rather than an NCCT chest. So indications as of now for going in for CT scan are, in a suspected case, if your chest radiograph is normal or you can't make out on chest radiograph that what is the pattern, you go in for a CT scan. If RT-PCR or CBNAT is not readily available as an emergency triage, it can be used if the X-ray doesn't help. Sometimes we do it in asymptomatic patients, or we even do it when RT-PCR is negative. For example, if you want to go in for a FES in an emergency setting, and the high aerosol generating procedures are planned, we can do an emergency CT scan as a preoperative measure. Now we come to, so this was for suspected patients, not yet proven. In proven patients on home isolation, basically all the red flag signs that we mark for the patient that you should report to a setting, which is similar to the signs of SARI, that respiratory rate goes up, SpO2 goes down. But in addition to this, there is one more indication I would like to bring your attention to, which is high-grade fever persisting beyond 5 days. We added this in the guidelines somewhere, in the beginning of the second wave, because we realized that a lot of people who had high-grade fever, which went on beyond 5-6 days, even without respiratory symptoms or drop in SpO2, invariably had COVID-19 pneumonia. So high-grade fever by itself, if persistent, is also an indication for CT scan. What is not an indication is a persistent dry cough alone, because that, as you all would have realized, is a very common symptom. So in the proven cases, we manage with bedside CXRs along with POCUS, which will be covered in the next talk. But in case of unexplained deterioration, or wherever the radiograph or patient really deteriorates, we will try to shift the patient down for a CT scan if patient is fit to be shifted. So typically in a admission, if patient has been there for 3 weeks or so, how many CT scans would he undergo? Anywhere between 1 to 3. And rest of the time we will manage with chest radiographs and bedside ultrasound. And how we are managing with the intensivists and sharing our expertise is all through Google Meet. And so they do share videos and show us the POCUS they are doing bedside if they want any input from us. And we are like participating in the virtual round with them and helping them in interpretation of the ultrasounds and X-rays also. In all suspected complications, particularly pulmonary emboli, we need to go in for a CT scan. And of course, imaging of other systems, head, abdomen. Now, these manifestations are so well documented. Today, we are not discussing COVID-associated mucormycosis much, but for us, of course, now in the last 3 weeks, all the imaging that we have done is paranasal sinuses much more than we have done the lung. And this is another free access document. So I showed you one document for chest radiograph, and this is another document which is available on the Society of Chest Imaging website, skirad.com, which also you can download and go through. Now, interpreting the CT scan. First, we come to diagnosis, then we will come to severity assessment, and then to complication assessment. Now, for interpretation of diagnosis, there are various guidelines, like RSNA guidelines says that you can call it either typical, indeterminate, atypical, negative, similar to what I showed in chest radiographs. But what has picked up the most is this Dutch paper, which uses the CORAD system, Coronavirus Disease Reporting and Data System. Just to remember, CORAD system is not any form of severity assessment. It is simply likelihood of this being COVID-19. Yeah? So if you do it in a suspect patient, it only tells you the likelihood of this being COVID-19. So if CORAD's 1 says no, that it is normal or non-infectious abnormalities, 2 says that these abnormalities are not COVID-19, something else. So 3 to 5 are the COVID-19 pneumonia, and 6 means that the patient is already RT-PCR positive. But remember, this is not a severity assessment, it's only diagnostic likelihood. Let's see what would qualify as CORAD's 5. So similar to the chest radiograph we saw, peripheral subpleural areas of consolidation. This is the classical pattern which we would label as CORAD's 5. Multifocal ground glass opacities. So, sorry, this had both ground glass and consolidation. The difference being these ones where you can still see the vessels through will be called ground glass. These ones which get very dense and you lose the definition of the vessels will be called consolidation. These are all ground glass opacities. And I'm going to show you one very characteristic sign which has come to be associated with COVID-19 pneumonia. They are called VES signs or vascular enlargement signs, which means that within this area of the ground glass or consolidation, you can see the vessel which is seen is dilated compared to the other similar peripheral vessels. So the one vessel which comes in is more prominent than the other areas. If you see of the lung in the peripheral third, you hardly see the vessels. And this is supposed to be because of the presence of microthrombi. And numerous named signs have been given to this VES or vascular enlargement, which is a very important diagnostic sign of COVID-19 pneumonia, and such as target signs, Gingo sign. And so these are all because of dilated. So if you see a dilated vessel going into this area, if you see here also, everywhere you will see prominent vessels. These vessels which go into the area of COVID-19 pneumonia are prominent and correspond to the areas of microthrombi seen on pathology. This is a 81-year-old male smoker, actually, who came to us, in the beginning of the first wave, and he was a long-term follow-up patient of ours of an early ILD. And if you see this patient, you can see that there's presence of paraseptal emphysema. The lesions are somewhat asymmetric. There's a lot of ground glass. Then there is a basal peripheral ground glass with, again, cystic spaces. And it was initially very confusing for us to see that, is this pre-existing ILD or is this COVID-19 pneumonia? So in patients like this of pre-existing ILD, of CTD ILD, it's very difficult to take a call on which of these it could be, because those NSIP, UIP also give a peripheral subpleural distribution. And then comparison with previous imaging is what is essential. And this patient had been on our follow-up for very long. And so we found new areas of ground glass and labeled him as a COVID-19 pneumonia. And he did not accept this diagnosis, but agreed to get his test done and came positive, refused treatment, and we lost him after 4 days of this CT scan. So pre-existing ILDs can be very confusing to take a call as to whether the superadded lesions are COVID-19 pneumonia or the ILD has worsened. Similarly, just like in RT-PCR negative patients, CT can help you pick up small areas and diagnose COVID-19 pneumonia. The reverse is also true. Several patients who are RT-PCR positive, the CT will be normal. Several will not go through this pulmonary phase in week 2 at all. As we are aware, the pulmonary phase will come in week 2, but several patients may not have involvement of the lung. And so, it has a 30% false negative rate. So CT is not a good idea to be used as a modality, for a mass population screening to kind of pick up the COVID-19, but it's a good add-on tool in a hospital setting that if you strongly suspect, but the RT-PCR is negative, one should definitely go in for a CT. To just revise what we saw, CORADs 1 to 6, so 5 and 6, these are the characteristic patterns, multifocal ground glass, and this is the organizing pneumonia pattern that I will come to. Tree in bud nodules, highly suggestive of tuberculosis, will go into a non-COVID pattern, so will be CORADs 2. This is also available in the same white paper which I referred to, is an open access download. Now we come to what role does it play in management. The most important is it has been used for after diagnosis severity assessment. So various scales are used for severity assessment, of which this 25-point scoring system by Pan et al. Has been most popular in India and being universally used, which is based on what percentage of each of the 5 lobes is involved. And the highest score possible is 25, and more than or equal to 18 is a bad prognostic indicator, and less than 7 is taken as mild disease, and in between being moderate disease. Similarly, there is a 40-point score, which is now based on bronchopulmonary segments rather than lobes. So it is a more detailed score, but less popular because, it is more time consuming to do. And herein the cutoff for prognostic bad prognosis is 19.5 or about 20. That's half the score. Now to look at a illustrative case, again, subpleural areas of consolidation, this is already some fibrotic phase. So CORAD 6, because it's RT-PCR proven positive, and severity will be 7/25. Patient is not on any respiratory support. Same patient which we saw earlier with classical findings. Now herein the score becomes 15/25. This is day 11 of the patient. So that's why patient has some denser areas of consolidation also. Patient on HFNC was maintaining a SpO2 of 92%. But what you will find is that in many patients, the CT score and patient's respiratory status is not matching, which means people can have very high CT scores, but require minimal respiratory support and vice versa. And why does this happen? The most important, of course, are the underlying patient factors and their comorbidities, but also what is important is CT morphology. For instance, ground glass is a better prognosis than dense consolidation. And we will go through a few cases quickly to understand the importance of CT morphology and the contribution of pulmonary vascular disease. Both of these add to the severity of the disease, but do not get reflected in the CT score, because CT score only tells you how much of the lung is affected. It doesn't tell you it is affected by what kind of lesion. So the type of lesion also varies according to the grade of lung injury. So for instance, if you get ground glass opacities like this, consolidation, but some septal thickening which is coming on, this is referred to as the crazy paving pattern. And this comes on during the mid phase of disease, and has been shown to be present in patients of DAD. Diffuse alveolar damage, as you are aware, is the pathological correlate of ALI and ARDS. And during the mid phase, means organizing phase of the disease, you will get this crazy paving pattern. Similarly, the organizing pneumonia pattern, this is called, central clearing is called the reverse Atolt sign. And actually during CAM, mucormycosis differentiation from this pattern has become very difficult. And this is the organizing pneumonia stage. What if you see a unilobar consolidation with some nodules and patient has persistent fever? What can this mean? So if you see consolidation like this, it can mean an organizing pneumonia phase. It can mean DAD. It can mean bacterial pneumonia, or if it's unilobar and subpleural, it can even mean infarct. So while ground glass opacity is mostly reflected COVID-19 pneumonia, consolidation can mean several of these things. Let's look at the, is CT a good modality to be able to predict reversibility? Because many times, you know, you're scared of secondary infections, you are dealing with diabetics, and you're deciding how much to taper your steroids, and going on radiographic and clinical clearance, trying to keep the tight balance between, you know, achieving a reversibility while preventing the patient from getting HAI. So some forms, we'll just see a case, for example, October, December 2020, that is during our first wave. So these are the subpleural areas of consolidation which were present. Already there were small, these black looking or cystic looking areas. What were these? Mostly these will represent either traction bronchiectasis or traction bronchiolactasis, and it may represent early honeycombing also. After 2 months, once the patient recovered, if you see that this areas of consolidation in the subpleural area have gone down, but diffusely there is a ground glass present, and also the bronchial dilatation and septal thickening has increased. Now these are areas which are going to take a long time to clear and likely to persist into the post-COVID phase. As you come down, as in ARDS, you will get these denser areas of consolidation. The point to remember is that these prominent bronchi do not always mean bronchiectasis. This dilatation may not be irreversible. As you can see in this patient also, that several of these areas reverse over a period of time, but some areas do have irreversible dilatation or bronchiectasis, and some have pneumaroceles also. So the denser areas of consolidation, it's not that they cannot reverse, but this diffuse kind of ground glass tends to stay on for a longer time. What are the finally imaging signs of fibrosis that you're left with? You can have volume loss, reticular opacities, bronchiectasis, and sometimes even honeycombing. Now in ARDS, in fibrosis, the controversy that how soon should you be starting antifibrotics, and if they have any role in addition to immune suppression and anti-IL-6 therapy, is the question that how early in does fibrosis set in DAD. So you see this dense areas of consolidation with septal thickening, what we called crazy paving. As we go down, this becomes even more dense. So organizing phase of DAD. So the radiopath studies, which have mostly been based on postmortems and postmortem biopsies being performed, have shown that fibrosis definitely starts to set in already by this stage. So there is a reluctance to use the word fibrosis in context of post-COVID, because it was seen that a lot of things which radiologists were labeling as fibrosis eventually cleared on long term. But having said that, there is a difference between mild to moderate and severe disease. In severe disease with patients with this level of DAD, we see that a lot of patients show no improvement in their ventilatory requirements, even over 1 month, 5 weeks, 6 weeks. So all those are patients with this dense consolidation wherein the fibrosis already set in. And as we saw in that comparison patient, traction bronchiectasis and honeycombing also comes early. Lastly, we address the complications. Complications, secondary infections and vascular are the most important complication, apart from air leaks, as we saw in that one patient. In vascular complications, see this large vessel emboli or thrombi, which we saw in the first wave, we see a lot less now, because right from after the first couple of months or some, everybody has been on prophylactic anticoagulation. And so we don't get like big saddle emboli or big large vessel emboli. But what we do get is microthrombi. Now, this is a patient also whom we lost, who was with us for a long time and went in about the 5th week of illness. And this CT is about the 4th week of illness. So if you see this ground glass, every ground glass does not mean that it is active inflammation and it is a reversible disease. Because in this ground glass, already, there are some areas which are hyperinflated, some areas which are showing ground glass, which means that all these areas will have a ventilation perfusion mismatch. And also patient had a left lower zone consolidation, had pleural effusion, then had a sudden deterioration. So it was thought that as patient developed a pulmonary embolism and patient came down for a CTPA, all the inflammatory markers were raised, D-dimer was also raised. We did not find very large vessel thrombus, but if you see what we found was, which your bedside echo would have revealed, that we found enlargement of the right heart. If you see the volume of the RV compared to volume of the LV, this RV is huge. So patient is in right-sided failure and the IVC is also dilated, but we can't find a big thrombus. Then why is the patient gone into right heart failure? When we did the reconstructions, we saw that there were multiple thrombi in the segmental level. And this is the vein which is going into the LA. This is the artery. So not only arterial, but even venous thrombi were present. And if you compare the vessels in the left lung to the vessels in the right lung, you can see so obviously that there is hardly any vessels seen in the periphery here, because there are so many segmental thrombi. So segmental and subsegmental thrombi, usually in walking patients in context outside of COVID-19, you may not be treating them with prophylactic anticoagulation, but in context of COVID-19, these can be so extensive that they definitely need an upgrade to therapeutic doses of anticoagulation. And even subsegmental and segmental thrombi, if extensive, can result in this level of right heart failure. Similarly, when we see a peripheral unilobar consolidation, you see, normally we saw this as a non-COVID pattern, because you would see it in strep pneumoniae or the typical organisms of CAP, but this is an RT-PCR positive patient. He's only 20 years old on home isolation, but has unexplained fever and some tightness in the chest. But whenever we see peripheral consolidation like this, we should suspect that this can be a pulmonary embolism with infarct. A unilobar consolidation should make you suspicious for an infarct. We asked the patient to undergo a CTPA, but patient was young, he was doing fine and was reluctant to undergo radiation again. But he did eventually undergo a CTPA after 1 week, and we did find changes of chronic thromboembolism on right side, as we found smaller segmental thrombi on left side, and patient required therapeutic anticoagulation after that, and he has done well subsequently. The other interesting thing in this story is we saw in the active phase, what do the small vessels look like? they show you vascular enlargement. In severe disease, they show you overt microthrombi. And then in the post-COVID era, they show you this peripheral arteriopathy. So this also contributes to PAH. You can see there is irregular beaded appearance of the peripheral vessels in the active phase. This has been referred to as the vascular tree in bud sign. We are used to the tree in bud sign within the airway in TB. This has been called vascular tree in bud sign, but you will see it in the subacute and chronic phases. This is patient in week 3. Although the disease is typically, this appearance is described in active phase, but when the microthrombi heal, if you see in the right lower zone here, they leave the vessels leaving beaded like this. So this peripheral arteriopathy will contribute to PAH in the long run also. And what we have been facing in India over the last 3 weeks has been this co-infections and super infections. This is the same patient we saw earlier, which, patient CT scan, and this is what it showed: extensive consolidation. There was an EDAC. This excessive dynamic airway collapse or tracheomalacia has to be interpreted with caution in ventilated patient, because you will see it very often and may not really represent a tracheomalacia, but this is an excessive respiratory collapse and depends on the ventilatory setting. So this was all not COVID-19 pneumonia, but HAI, and subsequently patient grew Acinetobacter baumannii. There's another patient of ours, a child who had leukemia and had COVID-19 pneumonia. The COVID-19 pneumonia recovered with just some fibrotic bands in the lower lobes, but patient had this persistent right upper zone opacity in the chest radiograph, for which we did this CT scan, and it shows a abscess-like lesion. So when you see a thick-walled abscess-like lesion, this is reflective of a GPC, gram-positive coccus. So most likely a staph pneumonia. But when you see an area like this is dense consolidation, almost mass-like with cavitation. Patient had grown Klebsiella. Patient also had COVID-19 changes, but we had to raise the possibility of mucormycosis in this. This appearance of mass-like with transfissural extension is very suggestive of mucormycosis. And even if you grow GNB or gram-negative bacteria, if you see this mass-like consolidation, one has to raise the possibility of CAM or COVID-associated mucormycosis. Similarly, the presence of pseudoaneurysms in mucormycosis is much higher than in other fungal infection, Aspergillus and Candida. Unfortunately, kappa or COVID-associated pulmonary aspergillosis is not giving us very characteristic imaging features and is very difficult to make out from GNB infections, but mucor gives very characteristic imaging and can be picked up on the basis of imaging alone. The patient of massive hemoptysis who came RT-PCR positive, but we saw mostly tree in bud nodules, so we labeled it as a non-COVID pattern, which means that there is no COVID pneumonia, only tuberculosis, a chronic cavitary aspergillosis, and a pseudoaneurysm. So we have a DSA in our special COVID facilities also. We went on and did pulmonary angiogram and embolized this patient. So concurrent COVID-19 and tuberculosis I have not seen in the same patient. Although anecdotally, people are saying that on steroids, they are seeing reactivation of tuberculosis or worsening of active tuberculosis, which is to be expected. But concurrent TB and COVID-19 in the same patient, we have not encountered. And post-COVID changes, we are not addressing today. It is a topic by itself, that how much is the clinical significance. But yes, COVID leaves changes which take a very long time to reverse in several patients, but we have seen that this process of reversal goes on for about 3 months. And so to summarize, we discussed what are the indications of doing chest radiographs and CT scans, besides respiratory issues such as falling SpO2 and rising respiratory rate. Persistent fever is also an indication. In high-risk patients, we should image more frequently. And remember that CT score does not always match with picture. So morphology is very important to take a call on reversibility and to titrate your immune suppression. and vascular complications and superinfections have now become the major contributor to morbidity in COVID-19. Thank you very much.
Thank you very much, Professor Bala, for that very informative talk on the X-ray and CT findings on COVID-19 patients and its clinical use. Now, I would like to invite participants or the audience to send in questions via chat so that we can forward or direct to our speakers at the end of the two lectures. Okay. Now, let me introduce our second speaker, Dr. Yale Tung Chang. Dr. Yale is an attending physician at Hospital Universitario Puerto de Hierro, Madrid, Spain. He is a chief of division of ultrasound in internal medicine. He is also a specialist in point-of-care ultrasound in the internal medicine department and Spanish COVID-19 specialized Isabel Sendel Emergency Hospital. His works within the point-of-care ultrasound focus includes echocardiography, abdominal, vascular, renal ultrasound, and gastrointestinal ultrasound. In addition to his responsibility, Dr. Yale is an associate professor at Universidad Alfonso El Sabio in Madrid, Spain, where he administered and teaches medical students on ultrasonography. He continues to serve as an expert on point-of-care ultrasound in many national and international courses. Dr. Yale was awarded an emergency ultrasound fellowship at Massachusetts General Hospital, Boston, USA, and his PhD work was on ultrasound and hemodynamics. He has a personal experience of being infected with COVID-19 himself 1 year ago, and he shared his images of his own lung ultrasound during his period of illness on Twitter, which you can find it on the YouTube. Today he will give us his talk on the topic of use of lung ultrasound in diagnosis and management of COVID-19 patients. Over to you, Dr. Yale.
Thank you very much, Dr. Bimal, and thank you all for joining to this radiologic imaging talk. And thank you for being there, and the honor for inviting me to give this lecture about one of my passions, which is point of care ultrasound. So without delay, let's get started. These are my disclosures. So to briefly give an introduction, we have to interpret the test we are going to talk about, point of care ultrasound, in this context, the context of a pandemic, the context of a place where almost anyone who comes to our emergency department, to our ward, will be have a highly suspicion to have COVID. That is the reason why we built in Spain the hospitals like Isabel Zendal only to treat COVID-19, because we face a struggle to deal with each patient. We didn't even have chairs to sit the patients on because they were coming in hundreds. In a place where only 100 patients could be admitted, we were treating 500, 600 just a year ago. And that's why we have places built like this one. This is Isabel Zendal. It's a quite open design hospital with normal beds and ICU beds, equipped with anything you might need. And in this context, anyone who comes with a positive test, with a positive imaging test, you almost could rule in that has the disease. And someone who doesn't have the patterns of have a normal imaging test, you almost could rule out because of the negative predictive value almost of 0 and the positive predictive value of almost 100%. That's not gonna be always the situation of this test of high sensitivity and specificity. As soon as we start to treat patients with other disease after the pandemic, after the high prevalence and incidence of COVID, we are gonna have more, probably we will still keep to have that sensitivity, but the specificity, as we have now seen, that it's gonna drop low below to the numbers we are used to see during the pandemic. And this is the algorithm we were using at the beginning of the pandemic. From one side, we can see that we were relying on chest x-rays that could take an hour to get it done because they have to clean the portable x-ray machine, the saturation, the auscultation, but the only confirmatory test, the real confirmatory test of having COVID is gonna be the PCR or the antigen test. Anything else just gonna give you clues, hints that probably it could be COVID. But the only confirmatory diagnosis is with microbiologic test. And this is one of the pictures I saw at the beginning of the pandemic, in which we can see that actually there were people using this kind of COVID stethoscope, which I used it for a while, and believe me, it's really hard to listen anything with that, and even that it's not safe. You have to be closer to the patient and its fluids in order to use it, in comparison to the normal stethoscope, which allows you to be at least 30 centimeters from the patient, compared to a common point of care ultrasound machine, which by its cord you can get even behind the patient 100 centimeters from him. And this auscultation was from a real patient, COVID-19 patient, with a fancy stethoscope, digital stethoscope, in which what we hear it's normal breathing, and its chest x-ray was also completely normal. And the saturation, sometimes you can even face that at rest a patient may have a good oxygen saturation. And with all that, what I mean is that chest x-ray, auscultation, and saturation has its own pitfalls, that we cannot rely solely on this to screen. And also the PCR. The PCR at the beginning of the pandemic could have a sensitivity of 60%. Right now, it's above 70, around 80% of sensitivity, much better than at the beginning. But at the beginning, whenever you had a negative RT-PCR, you couldn't rely and rule out COVID. That's why we needed something else. And that's why people like me, who had been using ultrasound for many years ago in other disease, in flu, in heart failure, in many other, we were wondering what would be the uses we could give to COVID using ultrasound. And this is a quite old study, but still its results are still useful nowadays, in which we compare auscultation, chest x-ray, and lung ultrasonography, and we see that the sensitivity, accuracy of lung ultrasound is much better to compare to auscultation or chest X-ray. You see in the interstitial, alveolo-interstitial syndrome, it's around 95% compared to the chest radiography, which is around 72%. So let's get into what is the lung ultrasound exam by talking a little bit, saying a little bit about the protocol of cleaning and preparing the equipment. The personal protective equipment is the same you will use to explore any COVID-19 patient, makes sense. And the equipment, the ultrasound machine you're gonna use, it's better to have one without too many buttons, corners, because anything of that you will have to clean it afterwards. And the ultrasound machine equipment, it's better to use portables rather than card-based ultrasound. As you can see here, many of these card-based have many buttons, corners, and spaces to put the gel bottles and wipes, anything, gloves that will make it harder to clean it afterwards. And although you might want using, especially if you are using the portable ultrasound device, at the beginning of the pandemic, we were using these central line covers that right after the studies of microbiologic studies of the virus, we're saying that it was quite easy to clean it and disinfect it. So after a couple of months using these covers, afterwards we were just using the ultrasound and clean it afterwards with some sterilizing products that doesn't harm the ultrasound probe. And if you have to choose between two card-based, try to use one without bottoms. And if you have several to choose, keep one only for the COVID area. That way you will save time by not having to clean it each time you go outside the COVID area. And inside the COVID area, take off anything that you are not gonna use, like any gel bottles, just leave one in the COVID area, any probes you're not using, and other products. The gel, remember that if you are gonna use a bottle of gel, leave it inside the COVID area, and don't scan people's suspicion of COVID than those confirmatory of COVID at the same time. You need to clean the ultrasound device in the middle, in between the test. And sometimes if you just have to scan one patient, you might want to get a basin with some syringes filled with gel or sterile individual pockets like this of ultrasound to don't need to take anything out from the COVID area. And this was the basin I was using at the beginning of the pandemic. I have my ultrasound device, some covers, my gel syringe, and my disinfectant. Remember that it's not only important the type of cleaning solution you are using, but also it's the same as important to leave it enough time to let the product to make effect. So it will be different depending on which product you are using. It will take at least minutes to be effective. And remember that the virus can live in any surfaces for up to 3 days. These are different solutions, cleaning solutions You may use the commonly used for cleaning or ultrasound probes, chlorhexidine, or for instrumental surgical products that you might find in any settings. And this will be the typical 3 basins I was using at the beginning of the pandemic. I started to scan my patient, and then as soon as I finish, I put it into a second basin where I could clean the device and then leave it to the dry, and then a third basin in the clean area where I put everything after I finished my exam. And this was in the second basin. After cleaning, I will put it in the clean area, drop it in the clean area. And the same goes for the car base. Once I finish the exam, I will clean it inside the COVID area, and then again in the clean area. I clean it twice, one in the COVID and one in the clean area. This was the second time. So how difficult is to do and interpret a lung ultrasound? Remember that this is not an anatomical technique. This is an interpretation of artifacts most of the time. And how difficult is to interpret those artifacts? You just need to keep in mind that lung ultrasound works like a densitometry. It will tell you what's the percentage, what is the equilibrium between air and water of the ultrasound of the lung. In the same way, it will do the same way it will be with chest X-ray. I will have, if I'm in one extreme side where it's the lung, a pathological field with air, we will have a pneumothorax. And if I'm on the other side, water field, it will be pleural effusion. And in the between these two contexts, I will have a normal chest X-ray, interstitial pattern, atelectasis, and consolidation. And which probe I'm gonna use to detect this equilibrium? You may have one of these 3 probes, which are the most commonly used: the linear high frequency probe, the curvilinear low frequency probe, and that is the phase array probe, also low frequency. And in each one, you might manage to see the ultrasound. You can use any of these 3, and you will get a good picture view of the lung. If you could choose, I would recommend you, advise you to use the curvilinear. It's the one which gives you a deeper view with a more panoramical view, and you will still get hints about what it is happening in the surface. Lucky for us, there's no bad acoustic windows in lung ultrasound compared to abdominal or heart ultrasound. And in order to perform this technique, I will put the probe over the surface of the skin, and this will be the image I get. We have one layer of skin as subcutaneous fat, a muscular layer, the rib and its casting its shadow, and the pleural line. So how difficult is to perform a lung ultrasound? I will put my probe in the transversal view and getting into view the rib shadows, and in between the pleural line sliding with some artifacts that later I will explain. But in COVID, this will be the typical view, the transversal view. But in COVID, we found that in the longitudinal view, it will give you much more information. As you can see here, I get a broader, more panoramical view of what it is happening in the lung. So in lung ultrasound, I'm gonna have three main findings, A, B, C of the lung ultrasound. The A stands for A lines. That's the horizontal pattern parallel to the pleural line that goes beyond to the bottom of the screen. That would be the same as putting two mirrors, one facing each other. I will get cast image that reverberates and reproduces to the infinitive. That will be the same that happens with lung ultrasound. That anything that is in between the pleural line and the surface of the probe, it will reverberate the ultrasound wave, and that will cast an reverberation artifact that stands for the A line. B for B lines, the B lines are in comparison to the A lines, it's a vertical artifact that comes from the pleural line and goes beyond to the bottom of the screen. We might find them isolated or confluent when it's hard to divide these B lines. This is the typical pattern, the typical finding in interstitial syndrome, and also is the main finding in COVID. There's a more specific sign, the light beam, which surrounding areas or normal lung, we might find this almost like a flash of B lines, confluent B lines that is commonly seen in COVID. There's no pathognomonic signs for COVID. This will just give you a hint of the involvement, lung involvement, bilateral usually with interstitial involvement, but it won't tell you that is definitely 100% COVID. It's impossible to do it with any types of imaging. And the C, consolidations, here it's not an artifact. Here we will see an hepatization of the lung, which is the only situation where we will see a real image and not an artifact, as well as the pleural effusion. Those will be real images and not just artifacts like A lines or B lines. And what will be what we have to rely in order to see lung involvement in ultrasound? What we will need is that just give you this example. We have lung pneumonia right inside the lungs, and each pneumonia has an inflammatory borders that crosses the pneumonia. And if I put my probe there, what I will see are A lines, normal A lines. And why it is that? Because I need at least to have the inflammatory borders to touch the pleura in order to see something. In this case, I will see B lines. And in case the pneumonia itself touches the pleural surface, what I will see is now the consolidation, as we can see here in this case. And that's the reason why if you don't get to see anything, there might be something inside the surface that the lung ultrasound is not able to reach. And that's the reason why also we will still talking about performing chest x-ray or auscultation. This is not gonna be a substitute. This is gonna be a complement to your physical exam and a complement to other imaging techniques like chest X-ray or CT. There's also been described irregular pleural lines, like the ones we see here, detached pleural lines or more thickened, like in this case that we can correlate with CT. In this other case, or small pleural effusions. This is not common to see big or moderate pleural effusions in COVID. Anytime you get to see a moderate pleural effusion, you have to rule out other disease rather than COVID. In COVID, what we tend to see just these small laminar pleural effusions that most of the time won't be seen in chest X-ray. Chest X-ray, you need at least 100 millimeters of pleural effusion in order to be seen. And CT, you need also quite a lot compared to to lung ultrasound, where with just 5 millimeters you can get to see it. These moderate, mild or moderate pleural effusions usually are a sign of other disease going on, like a malignancy or heart decompensated failure, etc. So in COVID, we might see these different signs. The normal A pattern, especially in the first days, where there's only a viral symptoms of upper respiratory tract symptoms, especially in the first 2-3 days of the beginning of the symptoms. And then soon after, if there's lung involvement, you will get to see irregular pleural lines, confluent B lines, isolated B lines, and consolidations, and eventually pleural, small laminar pleural effusions. So what would be the recommended lung exam protocol? Well, it depends. It depends if you're working in the emergency department or you are working in the ICU. In the emergency department, you might want to use ultrasound for triaging or pre-triaging, in where the saturation, solely the saturation, no, the auscultation has its own limitations. And in this setting, you might want to do quick scans in order to decide if this patient with COVID-19 like symptoms, but would well-looking appearance with good saturation, if there's no lung involvement, you might decide to discharge it right after, instead of waiting 1-2 hours to get a chest X-ray, or if you have many patients, in order to rule in the one who might need more tests, like the ones who have bilateral involvements. In the ICU, instead, you might need to use lung ultrasound to titrate the ventilation settings, or to rule out other disease, comorbid disease, like superbacterial infections, pneumothorax, to do a quick scan to rule out cor pulmonale secondary to PE or DVT, or to guide procedures, or to guide fluids. This will be radically different the use you will use in the outpatient clinic, where you might want to do scans, lung ultrasound scans, to assess residual symptoms, to assess new symptoms, to monitor the resolution of the of the abnormalities you've seen before in the CT or in another ultrasound in order to think of fibrosis, especially in any residual findings, abnormalities beyond the 12 weeks. So different indications with different scenarios at different settings. That's lung ultrasound. In each setting and each indication, I will give a use. And if I have more time, I can spend more time doing the ultrasound. If I have less time, I will need to do it more focused, in which the traditional decision flow, nobody would use ultrasound or any other imaging technique like CT or chest X-ray or labs. Just like Dr. Asha said before, you need to interpret it into the clinical decision flow, into the clinical decision tree in which we need to integrate it. So therefore, be flexible. Don't use it into rigid protocols, and be open to integrate it into the clinical decision. It wouldn't be prudent to take decisions only based on ultrasound, neither would be based on chest CT, but to integrate it, everything together. So how could use the ultrasound in a quantification manner in order to follow up and to measure the response to therapies? If I divide the thorax into 12 areas, these 12 areas are the anterior, lateral, and posterior in the superior and inferior aspects at each of these areas, at each of hemithorax. I will, if I find abnormalities in the anterior region, that would be more severe than if I find them in the posterior regions, which are the more common. And there is a score, the last score, in which the A lines, they will score as 0, irregular pleural lines or isolated B lines will score as 1, the confluent B lines will score as 2, the consolidation of the pleural effusion will score as 3. And this is a score, a very logical score, in which it depends on the priority. The less priority the A lines, the more irate, the more priority the consolidation and the big pleural effusions is marked for less aerated lungs. So it is, in reality, it is a aeration score in which the more aerated lung will find a more A-line pattern, the less aerated lung I will have more consolidated or with pleural effusion lung or with more prominent confluent B lines. Therefore, this is a logical score in which in the literature you might find many different scores that they might quantify B lines according to the degree of the involvement of the rib space, or they won't even consider the pleural effusion to a score. So you might find different scores, but they follow the same principle that the more higher score, it's the less aerated lung and the more severe involvement of the lungs. So how will I quantify or use this score I'm proposing? Imagine I have this area, and in this area I will scan through that area, and I find irregular pleural lines and consolidations. That scores for 1 and 3. I get the highest score, in this case 3, and that area accounts for 3, and I sum up to the rest of the 11 areas that will give me a score between 0 and 36. Whereas a low score means a mild involvement of the lungs, moderate between 8 and 19, and severe 19 to 36. These numbers might vary between the studies, but it is also the same principle. Lower score, mild involvement, high score, more severe involvement. And in COVID, especially in the ICU, we shouldn't be using lung ultrasound itself solely. We might benefit to a multi-window approach to our patients, or multi-organ, like the one we proposed in this paper we published already several months ago by a panel of experts, in which in ICU we found all these indications to phenotype and monitor all the patient for the cardiovascular assessment, fluid status assessment, deep venous thrombosis, tele-ultrasound to comment or to discuss the findings with more experts in the field, to titrate the mechanical ventilation guidance, and to differentiate other causes of respiratory failure. Like in this case of multisystemic inflammatory syndrome, in which they tend to affect the heart, we see that there's a myocardial involvement. Or in this other, with chest pain that also had a pericardial effusion. In this other case, sometimes to find a big hepatization might warrant us to start with antibiotics in order to rule out superinfection, bacterial superinfection, or to analyze the sputum, or to order a urine antigens for Legionella or pneumococcus, because you might be concerned. The same, you will be concerned to see one log consolidation on CT. And the ARDS, the pattern will give you, it's usually a high degree of lung involvement, high scores with spare areas, especially in the anterior aspects of the thorax, with subpleural consolidations, and combined with an hemodynamic assessment. Usually these patients, they have a low IBC or a normal heart focus assessment. And it's not hard in these patients to do a 2 compression test to rule out DVT. And one of the most fearsome complications, pneumothorax, due to barotrauma, we can easily detect them with ultrasound, and no need to take the patient, the unstable patient, to the CT room. Or this patient, which happens to be a nurse at the hospital, that had some pericardial symptoms, some chest pain after recovering from COVID, and had pericarditis, acute pericarditis. And I'm finishing. Some of the pitfalls in COVID is that, as I said before, these findings are not specific for COVID. Why we have so high specificity in our studies, because we have seen so many COVID-19 patients in the last months that suddenly we didn't have chronic heart failures or other disease, which might account for many of the patients we're going to start to see now, because the chronic heart failure pattern is going to be very similar to the COVID with B lines, or the PE, the pulmonary embolism or malignancy. Also, the metastasis will give me also subpleural consolidation and some comet tail artifact. So therefore, we still need the history taken, a good history taken, and good physical exam and other tests, and not only interpret the lung ultrasound by itself. And this is another case from 2 years ago, a flu patient has the same pattern with subpleural consolidation and comet tail artifacts. So at the end of the day, POCUS might help us, aid us into therapy, because especially the multi-window, multi-organ approach will allow me to diagnose other comorbid disease, because COVID-19 patients, it's not a it's not protector for other disease. So you might still get decompensated heart failure or pulmonary embolism, another disease. And correlating POCUS with CT, we find it in a quite early study in our group, a positive predictive value, a high positive predictive value, a negative predictive value of almost 100%, because at that moment, this is one of the pitfalls, we had only COVID-19 patients. And this is another study in peer review process that we found that lung score integrated with laboratory and some other demographic facts like the age might help us to predict mortality and need for admission. In this case, having a lung score, a high lung score with CPR, proteins reactive, C protein reactive above 70 at more advanced age, that was predict that it will need an ICU admission and hospitalization. So in these cases, what I'm not saying take the 7 as your rule. What I'm saying is integrate into your clinical flow the treat decision into some laboratory markers and physical exam markers, and with the previous history of my patient, and that will allow you to better discharge, manage my patient. As a bonus track, in this pregnant patient, we had this chest x-ray, and what found in the lung ultrasound was the pneumonia at that side, which happened to be bilateral involvement of the lungs. In this side was hardly seen. She was complaining also of chest pain, and what we found was a pericardial effusion. And like any other pregnant woman and COVID-19 patient, had a high D dimer, and we rule out the DVT. So in this case, POCUS gave me much more information. In this vulnerable population, pregnant, you might consider to save her from a chest x-ray. And this was another patient I saw a couple of months ago with bilateral lung involvement that my colleague asked me to perform because he was complaining of fever. And it took me 2 minutes to tell my colleague that the patient had COVID-19 pneumonia. What was my surprise? That the next day, chest CT was completely normal. And what the patient had in reality was a spondylodiscitis. What I was missing in this history was the physical exam, and also that my patient was a chronic patient with a central line because an hepatic cirrhosis, and central lines was the source of a back pain and the staph aureus that was isolated in the MO blood cultures. So the golden rule to do ultrasound, lung ultrasound, will be the clinical integration. Don't take lung ultrasound solely its findings, but integrate it into the rest. And we live in the world connected network in which teleultrasound will be the next step. In places where you might have not the skills or the knowledge to apply ultrasound, but you have the device, you might want to get into connection through a platform, through WhatsApp, through any secure, safe platform that is approved by your informatics department and approved by your hospital, and no exposing third parties, other patients. You might want to use it in order to connect to someone who is more expert than you at performing any technique. I do it with my colleagues also. When I have, anytime I have doubts about what I'm seeing, I will do connect with a more expert colleague and ask them. Don't be ashamed to ask, to question what you are seeing. Four eyes, they see better than two eyes. And in these days, artificial intelligence, deep learning, machine learning are emerging, these softwares are emerging. What we see is that we might apply this also ultrasound techniques with some ultrasound softwares that will help me to have more available this technique in places where might be hard to have people that know how to perform this type of ultrasound. In summary, we love ultrasound because it helped us quite a lot in this pandemic to be better physicians, to treat better and discharge better my patients, to rule out or rule in, especially rule in other disease, in which remember that lung ultrasound still is operator dependent, that so for some diseases are more accurate than chest x-ray and auscultation, and in some circumstances might have similar accuracy and even higher for than CT. At the end, lung ultrasound, chest CT, and chest x-ray, they will be complementary. They will complement each other at different points for different indications. This is not a substitute, it's a complement. Might avoid some CTs and chest x-ray. And the problem is that we only see the abnormalities that are in contact to the pleura. Lucky for us, many of the chest findings, they will be on COVID, they will be in contact to the pleura. The B lines, they are just alarm sign that will need to take us to look deeper to what is happening in my patient. It's not a diagnostic sign. And these B lines will help me to monitor global and focal changes of density. We can integrate lung ultrasound into different severity scores in order to monitor the response to therapy, the evolution, and monitor to COVID-19 lesions, especially to fibrosis, as this is a non-ionizing technique, a portable technique that might be good to for the outpatient setting. And for that, requires a formal training by experts. And this is my email address and my Twitter account. Feel free to contact me anytime you have any doubts, or you want to get or you have any questions. We might share the same question and we might help each other. And don't lose faith. We are close to the end as the war gets closer to higher vaccination rates. We will remember this period as a nightmare, and what I want to take from this experience, that it allow us to strengthen our bonds with other countries, with other multi-specialty teams, and allows us to be better physicians and better persons at the end. Thank you very much. And any questions, please feel free to and I will try to answer them.
Thank you very much, Dr. Yale, for that very interesting and very practical talk, especially cleaning aspect and how to use it in the context of the clinical scenario and how we put it to practice. We have got a few questions actually. Is Dr. Bala with us? Yes, okay. We got one question. What is the HRCT finding of acute fibrous organizing pneumonia? And it is, what is the features of HRCT findings of the acute fibrous organizing pneumonia? Is it like acute interstitial pneumonia or diffuse alveolar damage?
Yeah, so the AFOP picture is closer to the DAD picture rather than the acute interstitial pneumonia. You see, having said that, in context of COVID, if I was to specifically answer, if you otherwise ask imaging wise, what will AFOP look like? AFOP will look like more similar to DAD. But now that you brought up the topic of AIP, which means an idiopathic ARDS or in response to unknown stimulus oblique virus, there is another phenomenon that we are facing in India right now, that after we are, the part where I live, New Delhi, we are about 5-6 weeks away from our peak already. So we hardly have any new cases now, substantial wards emptied out. But what we are facing is a post-inflammatory syndrome, which I do not find reported in literature, which means that people after about 5 weeks are coming with sudden exacerbation. Some of them are again RT-PCR positive, but majority are not RT-PCR positive. And if we do see the CT scans in that, they are giving us an AIP-like picture, which means that there is an extensive new ground glass opacities which are coming in the lung. And these are all steroid responsive to the extent that we are finding several of these patients being steroid dependent, that the moment we tend to taper the steroids, the inflammatory markers go up. And again, this the ground glass comes back. So that is the AIP-like picture, which we are now calling. So it's like an MIS in children, except that here in adults, again, the lung is taking a hit rather than the other organ systems like in children. So in that we are getting this autoimmune kind of AIP. But to specifically address your question as AFOP and its CT picture, it's very similar to DAD and difficult to differentiate from DAD, except that AFOP will have more central areas of clearing and some reverse atoll signs. So it will get confused even with the secondary infection.
Are there any mortalities in these people who are coming back with this?
Fortunately, no. In fact, patients have this 24/25 scores, and we were thinking that what's going to happen if we have so many of these post-inflammatory syndromes, but they are responding well. Unlike, so the deaths that we are in, India is reporting now are patients who are in 5th, 6th week of illness who never improved, like, who have been on some level of, so what we have seen is that if the patient has to show a response to your immune suppression in the first 2-3 weeks, some response should start coming. If there is no improvement in the oxygen requirement or ventilatory setting, no improvement in CT scan, it's very difficult to expect a reversal after 3 to 4 weeks. And those are the patients who, we have started to lose now after 5-6 weeks of illness, because as you are all aware of, you are very comfortable with ARDS. And once it's going into organizing and fibrinous phase, the lung is becoming non-pliant, stiff, high PEEP requirements. Those are the people we are not able to pull out. And in addition, the mucor patients, but the late inflammatory patients come with this diffuse looking lesion, but it's steroid responsive. We have not lost any late inflammatory syndrome patient.
There's another question to you, Professor Bala. It says, we see self-inflicting lung injuries. What are the radiological changes in those self-inflicting lung injuries, can there be confusion with acute, AFOP, and the patients wrongly given pulse methyl pred? Shall I repeat it?
Yeah, no, I didn't understand what we mean by self-inflicting injury means.
What they meant was that when the patients were taking in the initial phase of the COVID stages, they take very large tidal volumes and getting their lungs damaged through self-inflicting kind of taking very large breaths, large tidal volumes. So due to that, they have seen that few changes in the lung, especially
Okay,
in the with the ultrasound.
and whether these are differentiated from AFOP and DAD or not,
yes.
That's the question. Yeah, so
Yes.
I haven't seen much of this, and I don't have experience with self-inflicting injuries, but to say what I anticipate would happen to the lung in such a situation, which means that at best we would have some level of alveolar injury, we would have some level of exudation into the alveolus, and we may have a little bit of volume loss over time. So it can simulate early change COVID-19 pneumonia, but it will not really simulate DAD. And AFOP, it's unlikely to simulate, but yes, it can simulate early, because some patients of COVID-19 pneumonia in mild to moderate category may just have some multifocal areas of faint ground glass, which you can get in whenever you have alveolar inflammation or limit, collapsibility due to any cause. But by the time we go into a fibrinous organizing phase, or we go into an organizing phase of DAD, that picture will not come with this level of injury alone, because in that it's not only exudation and inflammatory cells, because then we start to have microthrombi, we have large areas of organizing pneumonia. So that picture is not confused, moderate to severe disease. But yes, mild cases and early changes of COVID-19 may be confused.
Here's another question. What is the optimal timing of chest X-ray and CT of a critically ill COVID patient? When do you do the CT and the chest X-ray?
Yeah. So, here is the scheme of things that we follow. So suppose first the patient comes into our ER. So once if we take the patient through ER, so patient will undergo one chest radiograph there itself, but no patient, all will not undergo CT unless we have a very emergent situation. We first move the patient to the ward or ICU. Mostly we will manage over there with POCUS and chest radiographs. And only if we have an unexplained situation or a sudden deterioration it's not that we will do it in 100% patients. So we will take the patient up to the ward or ICU and stabilize the patient. And then on need based, maybe in 2 days, 3 days, when we need to bring down the patient, then we will bring down. It's not essential. There is no fixed time frame, that we have to do sequential CTs. We don't do it like that because, transportation issues and it's no point exposing people to so much radiation. So there's no fixed time point, but yeah, typically within the first 3-4 days of admission, the severe patients would undergo a CT scan. As you know that most of the management is very guideline based. And, depending on how much respiratory support, what the inflammatory markers are, and mostly chest radiograph and POCUS is enough to take the initial decision.
Okay. And do you, this chest CT, is it HRCT or the normal non-contrast CT do you do?
So by default, we do an NCCT, but in all those with high D dimers, we try to do a CTPA if the renal function tests are normal.
There's another question how to differentiate recovering pneumonia from organizing pneumonia in a chest X-ray or a CT?
Yeah, so, actually organizing pneumonia is also a reflection of recovery, and it's a steroid responsive lesion. So what happens is that more the call is that how soon or how slow to taper the steroid. Basically, if you're having a substantial amount of organizing pneumonia, it is going to respond eventually to steroids and eventually going to heal. But whether to continue steroid or to abruptly taper is again totally dependent on what the oxygen requirement is. You'll have several patients with some areas of OP, but not requiring any supplemental oxygen. Then the steroid will be stopped, all therapy will be stopped. And from the last wave, when we had already started running our post-COVID clinics, and calling these patients back, we realized that a lot of this OP is going to resolve. So patients with similar radiology are going to be at a different clinical severity level. So we have to put these two together to see. So OP is a healing phase of the COVID-19 pneumonia, and it will take several weeks or months to go away.
Okay. Thank you, Professor Balla. Now, I have a few questions for Dr. Yale. First one is, how frequent do you perform a lung ultrasound in COVID patients who are acutely ill and who are recovering?
That's a really tough question. I mean, we know that performing lung ultrasound on daily basis, it's not gonna help you for any instance. And my recommendation would be, like I said before, being flexible in this matter, especially when there's a switch into the clinical status of my patient. That would definitely be the most useful case scenario to do it. And in the follow-up, we actually have been follow up patients with COVID-19 pneumonia for up to 3 months, performing the ultrasound at each month. And what found is that many of the findings at point 0 at admission, they start to resolve depending on the degree of severity at the beginning. So it's a type of marker also of the degree of ARDS at presentation. So you might want to use it anytime there's a switch in the clinical status, in the worsening in the clinical status, and also for monitoring the evolution. But there's not a certain window that it must be followed, but maybe at each, in the outpatient clinic, at each visit, you might consider want to do it.
Okay. In your lecture, you mentioned that we can use the lung ultrasound to fine-tune the mechanical ventilation. Can you briefly elaborate on that, how we can do it?
I work in the medical ward. I don't work in ICU, but what my colleagues they use is an aeration score. That means that it tells me the degree of aeration of the lungs. So that will help me to know how much pressure I need to put in order to aerate the lung. And also it will allow me to detect the complications like barotrauma. Also, before reaching to that point, it will help me to see the degree, especially in to see the switch. When you pronate the patient, you will suddenly see that there's a rapid change in the score, especially in the posterior areas of these patients. You will, at the same as when you start with mechanical ventilation, you will see that the consolidations, they will start to disappear or to lower, and then start to appear the B lines. It's a dynamic continuum where there's A lines, B lines, and consolidations. In the same way, when you aerate the lung, you will get the consolidation, you will move into the confluent B lines, isolated B lines, and A lines at the end. So it's quite dynamic and helps you to see that you are going in the correct path.
Okay, thank you very much. And then there's another question. We have seen quite frequently the pneumomediastinum and pneumopericardium during the ICU stay in the patients of COVID. Have you seen that in your pandemic situation, and do you have any experience on detecting those using ultrasound?
I have seen several pneumomediastinum and pneumopericardium, but not in, I haven't had the experience in COVID-19. Probably in the ICU, they have seen it more often. But usually when you have a pneumomediastinum, what would be the image you will get? It will, you will see that the cardiac window, the parasternal window, is really hard to get that window because of the air surrounding the heart, and you will get a A-line pattern without lung sliding at that area, that place. The most the better window to get the view of the heart will be the subxiphoid, and by looking at there, you will see if there's air surrounding the pericardium, you won't be able neither to get that view. You will also get the A lines. So in those cases, you necessarily, as I said before, you need to complement the ultrasound. That might raise suspicion that there's a pericardium, not pneumomediastinum, but with X-ray, you will easily detect.
Thank you. And there's another question how long will it take on average basis to perform a comprehensive chest ultrasound on one patient?
5 minutes, no more. Also, please take into cautiousness my answer. It depends on the patient. The patient is moving, is not moving. I might need help, some help to move the patient to get the posterior rest, or I might consider not getting the posterior wrist because it's hard to mobilize the patient. But a common patient lay on the bed, it will take me 5 minutes. I put it on each area and it takes seconds to get the score at that area. For that, you need some training. I don't advise to start lung ultrasound in COVID-19 patients. Get some learning curve with heart failure, with normal lungs before getting into that.
Do you always do the all 12 areas of scanning, or just preferential areas of lung you scan for average patient?
That's a really good question. I will perform all areas when the first time I scan my patient, but then the following up will depend on the clinical suspicion. If I have the suspicion for pneumothorax, I will scan the anterior areas, only the anterior areas right next to the sternum. If I'm suspicion for pleural effusion, I only scan the posterior areas. And if I have pronated my patient, I will scan only the lateral and the posterior views.
Okay. Professor Balla, I would like to direct this question to you. The same question I forwarded to Dr. Yali earlier. What does X-ray or the CT you recommend if you have a suspicion of pneumopericardium or pneumomediastinum?
Yeah, so what we do, see, chest radiograph we have to do, chest radiograph, but every pneumomediastinum, we don't have to rush to go down to do a CT. 3-4 situations that you can have pneumomediastinum and pneumopericardium. One situation is that as I said, spontaneously in non-ventilated OPD home isolation patients are also getting. And this pneumomediastinum or pneumothorax, we assume, is due to rupture of a peripheral alveolus or a peripheral bronchus related to vigorous coughing, perhaps. Yeah? Because these patients have not received any respiratory support. Second category of patients is, of course, barotrauma related. Even those who are not on NIV, lot of HFNC patients are also getting pneumothorax and pneumomediastinum. And third reason is presence of pneumatoceles. And fourth reason is infected pneumatoceles, means that we have a secondary infection in the form of staph or mucor. So if it's just a pneumomediastinum, confined to pneumomediastinum and pneumopericardium, which is stable, your patient is stable, you don't have to rush for a CT scan, chest radiograph is good enough. But if we have cavitary lesions or we have a suspicion of BPF or any secondary infection, we will definitely go down for a CT scan. But every pneumomediastinum, we are not imaging because a lot of patients on HFNC are getting pneumomediastinum. If your patient is stable, you just follow it up on the radiograph alone. But as I said, any cavitary lesions or patient not doing well, we have to go down and see. And we have found BPF also in several patients. And like in BPF, in all situations, you know, these pneumothoraces are becoming very difficult to treat. We put the tube, the lung doesn't expand. Surgeon is not ready to take up at that time because patient is not fit for any form of GA and VATS. And unfortunately, all those who are coming out of the acute phase also, we find that the pneumothorax persists when they are coming to us after 3-4 months, because it goes into the phenomenon of what is called the trapped lung. Because eventually when the lung becomes fibrotic, it does not expand. So the bigger problem than pneumomediastinum eventually is a non-expanding pneumothorax or a hydropneumothorax, which we are stuck with also in many patients, which is due to two reasons. One is an active BPF, and second is fibrosis of the underlying lung, not allowing lung expansion. But pneumomediastinum alone, if your patient does not deteriorate, we don't have to take down for CT scan.
So you, how frequent do you monitor these patients with pneumomediastinum?
With the chest X-ray, typically I've seen them in the ICU do it like alternate day or every third day at least. So alternate day chest radiograph will be done. Yeah.
Okay. I think that's all we have received as questions. I would like to thank both the speakers, Professor Ashuballa and Dr. Yale, accepting our invitation and presenting your talks. Those are really wonderful and very informative for us, and we learn a lot. And thank you very much again, spending time, valuable time with us. And also I would like to thank our president and the colleagues to helping us to organize this webinar, actually all webinar series. And thank you all participants as well coming and listening to us on this Zoom platform. And I would like to wish you all safe and be safe throughout the pandemic. Thank you very much again. Bye-bye.
Thank you, Dr. B.
Thank you.
Thank you. Good night.
Good night.